Marnie Nabudni, and welcome everyone to Grand Round for this week. Please turn the sound down on your phones, that'd be great. Excellent. Apologies for the slight delay due to technical difficulties, but thank you to the audience for playing along so beautifully. Okay, welcome, Mark.
Great, thanks so much, Jo. Lost audio. Can you hear me now?
Yeah, we've got you back now, Mark.
Great, fantastic. Well, thank you for the invitation to present at Grand Round, and thank you to everyone in the audience for being accommodating with the lack of slides. I've lost my presenter view, and so if it's not as slick as you might expect, that's the reason why, not that I'm underprepared. In case to point, I can't navigate through the slides.
Come on. It should work, it should work, it should work.
Excellent.
Just use
those ones? Okay, great. So for the research that I'll be presenting today, I don't have any conflicts of interest, but I would like to acknowledge my funding. So I'm supported by a Hospital Research Foundation Group Fellowship, and they are supporting the vitamin C research that I'll be presenting this afternoon. And I've recently been awarded an NHMRC investigator grant, which will support 5 years of glucose research, but I won't be covering that during this talk, because I really want to focus on what we've done in 2022 and a little bit on the direction that we're heading. So, no sound? How good's this?
I have sound.
Yeah, you should. Sounds fine.
I
have sound.
Right.
I have sound.
You've given me a drawing icon now, Jo.
I'm sorry.
That's all right. Okay. All right, so what I'm going to cover is who we are in intensive care research, and essentially everyone is here from intensive care research, so you just really need to look around. I'll be discussing 2 of the multi-centre trials that we have running at the moment and 2 of the investigator-initiated trials that are up and running. There we go. So in terms of who we are in intensive care research, as Jo mentioned, I've only been in the job for 12 months, and if we're going to discuss the ICU research unit, it's important to acknowledge Professor Marianne Chapman, who's in the room at the moment. Marianne was the director of research, or has been the director of research in the ICU for 25 years. She's a doyenne of critical care research in Australia and has defined much of what is now known about gastrointestinal dysfunction in critical illness, including her seminal first author NEGIM publication in 2018, which was the target study, which defined the optimal nutrient regimen to deliver to critically ill patients. Marianne supervised my PhD, and she's also mentored and supported really the next crop of ICU researchers from South Australia. So that includes Adam Dean, Matt Maiden, Yasmin Ali Abdulhamid, Palash Carr, and she has been a mentor and a friend for this next crop of researchers. In conjunction with Michael Horowitz, Chris Rayner and Karen Jones, she set up the NHMRC Centre of Research Excellence, the first one that was awarded in South Australia, received back-to-back funding through that, and has really built the RA as an internationally recognised critical care unit. So she's handed over a very robust ICU with established postdoctoral researchers and experienced research scientists, and I'm very grateful. And I've got huge shoes to fill. Our team in ICU, we've got experienced research coordinators and nursing staff who have decades of experience in conducting ICU trials. We have 2 research scientists. Dave Evans is in the room, sits on the ethics committee and helps guide our protocols. Mark Finnis, who you all know, is a retired intensivist and a biostatistician who helps us with our stats. And then among the active intensive care group, there's a very large number of PhD trained intensivists with diverse research interests. So I've got an interest in glucose and neurocritical care and sepsis. Marianne, as I mentioned, is an expert in enteral nutrition and the critically ill. Ben Reddy has an interest in physiology and vascular reactivity. Arthur Flaboris is a world leader in the deteriorating patient and MET. Our director, Chris Sundaranjan, has an interest in the deteriorating patient and safety and quality. Matt Maiden has got experience with large animal models and database management. James Malika, the recent appointment at the Royal Adelaide Hospital, has a PhD from Oxford and has experience in the deteriorating patient and data analytics. And then we have 2 registrars with PhDs who are our postdoctoral research fellows, essentially from the medical side. But the unit really is renowned for its nutrition work. That's what Marianne has built. And I think our most productive work comes from the nutrition side, and that's being led by Associate Professor Leanne Chappell, who's done extraordinary work, and some of which I'll be presenting over the last 5 years. And she's currently supervising 2 PhD students, Matt Summers and Beth Viner-Smith. So what we do in ICU research is a lot, really. These, if you can see on your screens, these are all the trials that are actively running in the unit at the moment. And I divide the trials into the multi-centre trials, the majority of which are coordinated through the Australian New Zealand Intensive Care Society Clinical Trials Group, or the ANZIC CTG. Then we have the Passion projects. So these are investigator-initiated trials, usually single centre, run out of the Royal Adelaide Hospital. And what we do really well here at the RA is small physiological studies. And then finally, we have our industry trials, and we are the largest intensive care unit in Australia. We have a very heterogeneous patient mix with trauma, burns, haematological malignancy, general medical, general surgical. So we are attractive to industry looking to trial drugs in the ICU. And so we have a number of those industry-sponsored trials which help pay for things like the research scientists. The trials that I'll be presenting today are 2 of the ANZIC CTG trials, Bonanza and Target Protein, and then 2 of the investigator-initiated trials, which are HiVis and PROMS. I was going to go into some more depth about what the ANZIC CTG is, but I think looking at the audience, everybody appreciates the ANZIC CTG. It is a world-renowned research unit of dedicated intensivists from around Australia, intensivists, nurses and allied health from around Australia, who combine together to answer clinically important questions that require large sample sizes. So because the ICU is a heterogeneous group of patients, we often need large sample sizes to answer questions like how much oxygen should we be giving our mechanically ventilated patients? So there's this collaborative that exists that get together, seek funding and answer these questions. And in the last 30 years, it's been an extraordinarily successful research group. It's raised it's been awarded rather, over $130 million in NHMRC Category 1 funding, and routinely publishes in the highest impact journals such as NEDGEN and JAMA. The RA as a contributing site has contributed heavily to many of these papers, and the research nurses and coordinators in the room are really the heroes driving these papers and the data collection. So that includes things like the ICU ROC study, as I said, that defined the oxygen targets, the appropriate oxygen targets in the critically ill. The Target study, where Marianne Chapman was the lead author. The recently published PLUS trial comparing balanced crystalloids versus normal saline in the critically ill. The adrenal study, defining the role of steroids in septic shock. The transfuse study, looking at whether old red blood cells are worse than new red blood cells for patients requiring a blood transfusion. They're not. The ARISE study, which was led by Sandy Peake from the Queen Elizabeth Hospital, looking at the appropriate way to resuscitate patients with septic shock. And the DECRA trial, looking at the role for decompressive craniectomy for patients with refractory intracranial hypertension. So these big, powerful studies in NEDGEM have been published by the ANZIC CTG in the last 10 years, and the RA has been a contributing site to that, led by Marianne, and with most of the work conducted by the research coordinators sitting in the back row. But the trial I want to present today is the Bonanza trial. So this is an ANZIC CTG trial running in the unit at the moment, looking at a new intervention for managing secondary brain injury in severe TBI. So severe TBI, patients presenting with a GCS less than or equal to 8, it's a massive problem. 30% mortality for severe TBI, 50% of patients have a poor neurological outcome, and it's extremely expensive. It costs the Australian government $5 billion a year. So it's an important problem to try and solve. And the role of the intensivist in managing brain injury is to try and prevent secondary brain injury. So hypoxia, hypotension, edema all drive secondary brain injury, which damage neurons and ultimately leads to worse neurological outcomes. And despite that being the aim of the intensivist and the intensive care team, we don't have particularly good tools at measuring how secondary brain injury is occurring. And really the only thing we have to go by is the intracranial pressure monitor. So of all the squiggly lines we have up on the screen, it's usually the purple one. And the intensive care team has a tiered protocol of increasingly aggressive therapies to try and lower the ICP. But as a measure of secondary brain injury, it's not particularly granular and it's a very late sign. So we know the Munro-Kelly doctrine, the brain sits within a fixed cranial vault with 3 incompressible fluids, blood, brain, and CSF. And the brain can compensate to a point as the mass increases within that vault. And so the venous blood volume will decrease, the CSF volume will decrease. And then there's a tipping point where small increases in mass or swelling will lead to a large increase in pressure. And so you appreciate that major secondary, I'm just getting some feedback here, Joe. Thank you. Thanks. So you can appreciate there will be secondary brain injury potentially occurring up until the point where initially you'll get a rise in the ICP. And so there are units internationally that use other modalities to try and determine whether a secondary brain injury is occurring. And one of those is the brain tissue oxygen monitoring probe. I did my postdoctoral studies in Cambridge in the UK, and routinely every patient in the unit there at Addenbrooke's Hospital would have a brain oxygen monitoring probe inserted. And there are 4 key points to think about when you think about brain oxygen monitoring. The first is that ischemia is a major cause of secondary brain injury. The second is that low brain oxygen tension occurs frequently in TBI, and there's a strong association between low brain oxygen tension and poor outcomes. And finally, really simple interventions can improve brain tissue oxygenation. So there's things essentially with the ventilator, increasing the partial pressure of oxygen in the blood, increasing the partial pressure of CO2 and increasing cerebral blood flow, red cell transfusions can all improve brain tissue oxygenation. But this has never been trialled in a randomized controlled trial. And so Bonanza with the ANZIC CTG is trying to answer that exact question. So the inclusion criteria will be patients presenting with severe TBI with a GCS less than 8 who ordinarily would have an ICP monitor inserted. And at that moment, they are randomized and all patients will have not only an ICP monitor inserted, but also a brain tissue oxygen monitor. And they'll be randomized to receive standard care, which is a tiered protocol of just ICP management, or a protocol based on the brain tissue oxygen monitoring and the ICP. And what you can see on your screens, this is deliberately a very busy slide. This is the intervention arm of the trial. It's extremely complex. It requires high levels of research nurse coordinator time to coordinate at the bedside. And you can see that there are essentially 3 scenarios. You can have low brain tissue oxygen tension, normal ICPs. You can have low brain tissue oxygen tension and high ICPs, or the worst case scenario is you'll have low brain tissue oxygen tension and high ICPs, and you have tiered protocols for each of those 3 things. The primary outcome of the Bonanza trial is the proportion of patients having a favourable neurological outcome at 6 months. So we know that 50% of patients have a poor neurological outcome. The study is powered to show an absolute risk reduction in 10% of those patients having a poor neurological outcome, so a 20% relative risk reduction. I think this study is really testament to the collaboration that occurs at the Royal Adelaide Hospital with these big clinical trials. So for this to work, we have Dan Ellis and the trauma team who are identifying patients and flagging it to our team and the neurosurgical team. Adam Wells leads the neurosurgical side in inserting these brain tissue oxygen monitors, and Ben Reddy from the ICU side helps coordinate the tiered protocol. But ultimately, it's the whole ICU, not the ICU research team. We've got the nurses on board and the doctors at the bedside who are willing to enact this fairly complex protocol, which is outside of our standard of care for the ultimate aim of a international randomized controlled trial. And we do have buy-in from the whole unit for these trials, which is so important. Just an issue on consent. So the Bonanza trial has a waiver of consent model and then a delayed opt-out consent if the patients regain recovery, which is a really neat way of doing research in TBI. ICU and particularly brain injury is a really difficult condition to get consent in. So routinely you're getting consent from next of kin who are having the worst day of their lives. Their loved one all of a sudden has suffered a brain injury. So it's very hard in that setting to get prospective consent and go to them when they're dealing with all that trauma and say, actually, we've got this new monitoring device, we're doing this and that. It's challenging. And It's also important, I think, to reflect on the expectations of the family. And there's this great study that was published in the BMJ in 2005, where these researchers looked at US soap operas over a period of 10 years. So 9 soap operas. This was Days of Our Lives, The Bold and the Beautiful, The Young and the Restless. And if you're a character in a US soap opera, you've got a bad chance of getting a coma. So 64 of these characters suffered a coma for a really long period of time. They're in a coma for nearly 2 weeks. Now, we know that severe TBI, a third of patients die, 50% of patients have a poor neurological outcome. But with the information where our families are getting the expectations of what to expect, 89% from the US soap operas had a full recovery, and the majority of those recovered fully and just woke up on the day that the coma resolved. And so it's balancing those expectations, and you can imagine going and getting consent when the families are expecting that sort of outcome, but the reality is a lot worse, is really challenging. And so, yeah, the Bonanza trial is a waiver of consent model, which makes the whole thing a whole lot easier. So the next multi-centre trial actually crosses the boundaries into a passion project for our unit. This is a trial being led by Leanne Chappell, who's supervising Matt Summers there, who, despite that power jumper, they are actually his own teeth. And it's a trial looking at the effect of augmented protein delivery for critically ill adults. And the key question or thing that we're trying to solve here is critical illness weakness. Critical illness weakness is not a sexy condition. It's not covered in the media that often until really COVID hit. And so this is a snapshot from CNN Health of a bodybuilder over 100 kilos, built like John Fraser, who before getting COVID looked like that. And then he was on the ventilator for 3 weeks and came out looking like that. And I think the quotes are really, they hit home. So I woke up and looked at my arms, my legs, and my muscles were gone. I was kind of freaking out, like, where are my legs? Where did my legs go? And this is something that is ubiquitous among our ICU patients. This isn't just bodybuilders who start out looking like John and end up looking like Flash. This happens to all patients. And one of the benefits of these big multi-centre trials where we look at a lot of integral granular outcome data is you get these secondary informations that aren't secondary information that's not part of the original trial. So the ICU Rock study that I talked about earlier, that had 1,000 adult patients admitted to the ICU who had a mean age of 58 years. They were pretty young and they weren't ventilated for very long. So a mean duration of ventilation of only 3 days. And the ICU Rocks investigators followed these patients up, and at 180 days, less than a quarter of these patients had returned to their pre-morbid walking ability. So it is ubiquitous among our ICU patients that they become weak and that their function is impaired. And an answer to this may be that we may not be giving them enough protein. So we know that if you supplement with protein, you can increase protein anabolism more than protein catabolism, and you'll build muscle bulk. And so the question could be asked is, are we giving our critically ill patients enough protein? Sorry, mate.
No, you're all good now.
Okay, all good. Okay, so the question is, how much is enough? The European and Americans have some disagreement on that, but generally it's somewhere between 1.2 and 2 grams per kilo. But there's essentially no evidence to guide that. So either very low quality evidence or no evidence. And there was a really nice international survey published in 2018 by Emma Ridley from the Alfred, who looked at the real world prescribing experiences. And even though these are the recommendations, most patients fail to meet that target and fail miserably. So an average of 0.6 grams per kilo per day are delivered internationally, and the Australian data reflects that pretty closely as well. So to try and overcome this problem, Leanne designed a feasibility study. This was a randomized controlled trial across 6 centres where 120 patients were randomized to receive 1 ml per kilo per hour of our normal protein feed, 63 grams per litre, or 1 ml per kilo per hour of a higher protein feed, 100 grams per litre. And it was a feasible study. They were able to get treatment separation. You can see in the intervention arm there that the patients randomised to the 100 gram per litre were achieving protein targets consistent with the upper limit of the American guidelines. It was tolerated, it was safe. And so with these data and the big problem that is critical illness, Marianne, Leanne and Adam Dean were successful with a recent MRFF grant and have been awarded over $2 million in funding to conduct the target protein trial. which is a cluster randomized, cross-sectional, double crossover, registry embedded clinical trial. And with a name like that, you can see why they chose to go with target protein. And the question they want to ask is, does increasing protein delivery improve a patient-centered outcome, which is days alive and outside of hospital at 90 days? It is a cluster randomized design. There are 12 sites contributing, 8 sites contributing over a 12-month period. And in the cluster randomized design, each site will have the randomized cluster per 3-month period. So every patient in the unit for a 3-month period will be randomized to a dose of enteral protein. So whether that's protein plus, the standard formula, or protein intense. All other components of the nutritional care will be up to the treating intensivist, but the whole unit on bulk will receive either normal protein or protein intense, and then we'll have a 3-month period of the other formula. The primary outcome, as I said, is days alive out of hospital at 90 days. And over a 12-month period, they're expecting to recruit 3,000 patients with the aim of showing a 1-day difference in days alive and outside of ICU, which may not seem like much, but I think the important point to consider here is this is a really cheap therapy. You're essentially just tipping protein down the nasogastric tube. It's cheap as chips. And everyone gets it. So you've got a cheap intervention that every single patient will get. And so if you are able to show just 1 day's difference in days alive and out of hospital at 90 days with such a cheap and ubiquitous intervention, that will be an important outcome. And I suspect that the results of this trial will be published in an equally high journal to the original target study. And we are just approaching our 1,000th patient. So we're getting there, and the recruitment's been fantastic. So you may well ask, well, surely it's not just tipping protein down the tube that's going to convert that ICU patient into the COVID warrior that is Nick Edwards. And it's a fair question. And to try to answer that question, Leanne and Marianne designed this incredible study. This is really a fantastic study that was published in the Blue Journal last month. I think it's one of the best pieces of research to come out of the Royal Adelaide Hospital, certainly the last 12 months. I can say that because I had nothing to do with it. I'm just presenting the data. And so what they wanted to do was answer the question of, if we tip more protein into the gut, will that actually be incorporated into the muscles and make a difference with the organ that you want to affect? And so how's this for a study design? They got a radio-labeled tracer and injected it into a cow. They then milked that cow, and the milk contained the radio-labeled tracer. And by infusing that post-pylorically, they were then able to measure the radio-labeled tracer in the blood to determine the digestion and absorption of the tracer. And then by sequentially taking muscle biopsies to work out how much of that tracer was embedded in the skeletal muscle. So that's an incredible study design. This is a really difficult study to run. They compared 12 healthy volunteers to 15 critically ill patients. You can see there that blood samples are taken over the course of 8 or 9 hours, and there were 3 muscle biopsies. And I just want to emphasize how hard it is to consent families to get a muscle biopsy in the critically ill. That's what a muscle biopsy needle looks like. It's a javelin with a suction port. And as I said, when you're consenting critically ill patients, you're going to them they're going to the family members on the worst day of their lives and saying, actually, while your patient's got a head injury, we'd love to stick this big needle in their leg and take out some of their muscle because we're concerned about muscle weakness. That's a hard sell. And they managed to get 15 families to consent, which is a fantastic job. And it was made even harder by the ethics committee making Leanne put a photo of that muscle biopsy needle within the consent form, which I think is so unfair, because you don't go for your cardiac surgery and go, oh yeah, here's the surgery, but this is what a bone saw looks like. But nevertheless, they got all the patients recruited, and the results I think are fascinating, even if you're not interested in nutrition. So digestion and absorption, and measuring the amount of radiolabeled marker in the plasma was similar between ICU patients and healthy subjects. Now that's different from the other macromolecules. Marianne, over the last 10 years, has shown that lipid absorption is impaired in the critically ill, and that was a study led by Yasmin Ali Abdulhamid, and that carbohydrate absorption is attenuated in the critically ill, but it doesn't appear that protein follows that same line. But the money is what happens in the muscle. And so looking at the muscle biopsies, there's 40% less incorporation of that radio-labeled amino acid in the skeletal muscle. So the deficit seems to be in incorporation of the muscle. And that's a fascinating pathophysiological mechanism to define, which was led in a single center study at the Royal Adelaide. Okay, so the question is, what about that question of tipping more protein down the tube? Is that going to make a difference? And there's two ways that our unit is answering that question. The first is with the target protein study, that cluster randomized controlled trial, but we're replicating that study design in the ICU patients, but this time not having a healthy volunteer arm. This is a randomized controlled trial where 20 critically ill patients are randomized to a 20-gram radiolabeled protein load delivered postpylorically, or a 40-gram protein load delivered postpylorically, and the same period of muscle biopsies. Now, the final patient, the 20th patient, was recruited on Friday. So I don't have these data for you, but it will be out in the next 12 months. And this will be another really high impact paper that will help define what the optimal regimen is for delivering food to critically ill patients. Okay, so the final study I am going to present is the High-Vis trial. This is my pet project and a project which is funded through the Hospital Research Foundation Group. Vitamin C, I find fascinating. The story of vitamin C, it's the first ever controlled clinical trial in humans was conducted in vitamin C by James Lind. And James Lind was a Scottish physician in the British Navy in the mid-18th century. And at that time on the round the world voyages, about half of the patients would die from scurvy. And so James Lind conducted this controlled clinical trial where he got 12 sailors and randomized them in groups of 2 to a quart of cider a day, which doesn't sound too bad, 6 spoonfuls of sulfuric acid a day, which isn't great, some barley water, a cup of seawater, again, not great, a spicy paste, whatever that was in the 18th century, but probably not great. And then the final group were randomized to a meal of 2 oranges and a lemon a day for a week. And the sailors that got the oranges and lemons recovered within that week and returned to work, and the 10 other sailors died. And it was at that point that they realized that citrus was a treatment for and preventative for scurvy, and citrus was then distributed throughout the US Navy, which is why, sorry, the UK Navy, which is why they're known as limeys to this day. Vitamin C is the primary antioxidant used and depleted during oxidative stress. So scurvy is sort of the end point of the disease process, but vitamin C is the primary antioxidant in our body. And what drives sepsis-induced organ dysfunction is oxidative stress. And so if you measure vitamin C levels in the plasma of patients who become septic, a proportion of patients, about 10%, reach levels consistent with scurvy in the ambulant population. But almost every patient gets every septic patient gets hypovitaminosis C. And so the interest in vitamin C as a supplement, or sorry, as a pharmacotherapy in ICU has been around for a while in terms of the concept of metabolic resuscitation, but it really gained traction following the publication of this paper by Paul Marek in Chest in 2017. This is a really controversial paper, and what Paul Marek showed in a flawed study design, so retrospective before and after study, is that in his unit before administering metabolic resuscitation, the observed and expected mortality for septic shock was about 40%. They then instituted metabolic resuscitation where patients got steroids, thiamine and vitamin C at 6 grams per day and showed a dramatic, some would say, most would say unbelievable reduction in mortality from an expected mortality of 40% to 8.5%. And it's since come out that that probably is falsified, and I think he might be in a little bit of legal jeopardy about these data. But nevertheless, this really was the catalyst for large randomized controlled trials to determine the efficacy of vitamin C in sepsis and septic shock. So that was published in 2017. And then if you think of the lag time about getting trials up and running and published, it took about 2 years before we had 4 trials published in JAMA in the space of 6 months, randomizing patients to vitamin C at a dose of 6 grams per day or placebo or usual care. The ANZIC's CTG led the vitamins trial, and all the trials showed the same thing. There was no difference in primary outcome of mortality and no difference in secondary outcomes. And then, while I was preparing my trial of megadose vitamin C, there was this trial, the Lovett trial, published in the New England Journal in June of this year. This was from the Canadian Critical Care Group, a very reputable trials group internationally, who published a very robust double-blind randomized controlled trial of high-dose vitamin C for patients with sepsis and septic shock. and they used a dose of 200 milligrams per kilogram of vitamin C a day. So in an 80 kilogram person, that would be 16 grams a day. So a higher dose than has been used previously. And their primary outcome was mortality or persistent invasive organ support at 28 days. And in their adjusted analysis, the point estimate favoured harm with a vitamin C arm. So pretty concerning, which stopped my study in its tracks, and I had to go to the Data Safety Monitoring Board and the respective ethics committees to determine whether or not we could keep going. There are significant differences between this trial design and what we're using, the most important of which is the formulation. So all the trials of vitamin C in sepsis to date have used ascorbic acid with a pH of 5 to 5.5. Our trial is the first to use sodium ascorbate, so the base salt of vitamin C, which has a pH of over 7. There are some other differences that I don't have time to get through in this talk, but essentially we've been given permission to continue our trial here at the Royal Adelaide and Monash and the Royal Melbourne. At the same time that the Lovett trial was published, they published a systematic review and meta-analysis in NEGM evidence, and all the evidence combined would suggest the point estimate favours vitamin C for the effect on early mortality, and you can see the upper 95% confidence interval is 1.06. Okay, so introducing the concept of megadose vitamin C. So this is work that got underway when I was in Melbourne at the Florey Institute over there, looking at sodium ascorbate at a dose of 3.5 grams per kilo in septic sheep. And so they've got this fantastic animal critical care unit to a sheep. And what we were doing was we randomized 10 merino ewes who were young, about 2 years of age, and they underwent 2 surgical procedures prior to the experimental day. So we externalized the carotid loop and put flow probe catheters and pulmonary artery catheters in these sheep. And we placed a flow probe in the renal artery and then oxygen monitors, similar to what we're using in the Bonanza trial, in the renal cortex and the renal medulla. The sheep were then allowed to recover with all of these tubes and wires hanging off them. And then at 2 weeks, they underwent the intervention, which was an infusion of live E. coli. And we allowed the sheep to get septic and into septic shock and develop a vasopressor requirement, and then gave them either sodium ascorbate at 3.5 grams per kilo over 7 hours or a vehicle. And the results were fascinating. This just shows that you can find any picture you want on the internet. I searched sheep and high-vis, and there's a picture on the internet of a sheep in a high-vis jacket. So in panel A, we have the black squares are the 5 sheep that received megadose vitamin C, and the open circles are the sheep that received the vehicle. And in terms of the mean arterial pressure, it was consistent between the 2 groups with or without the use of noradrenaline. And so in panel B, which is where the money is, those sheep who were randomized to the vehicle had progressively increasing amounts of noradrenaline, which is what we would expect in untreated septic shock, up to 1 mic per kilo per minute, which is a hell of a lot of noradrenaline. Those 5 sheep who were given megadose sodium ascorbate were weaned off noradrenaline completely, and that's without antibiotics. Looking at the other parameters, they had resolution of the distributive shock state. So the black circles again are the vitamin C arm. The cardiac output decreased, the heart rate decreased, the total peripheral conductance, which is the inverse of total peripheral resistance, decreased. So they had more squeeze in their peripheral vasculature. The fever resolved. And then when you look at the renal data, the renal blood flow decreased, consistent with a drop in the cardiac output. And I'll just draw your attention to panels E and F. So renal medullary ischemia and hypoxemia is what's thought to contribute to sepsis-induced acute kidney injury, and it occurs frequently and it occurs early. And what we were able to show is that for those sheep who were in the sodium ascorbate arm, they had preservation of their renal medullary oxygen tension, whereas those in the vehicle arm developed the profound renal medullary hypoxemia that we would expect. And there was no change in the renal cortex, which has a preserved blood supply. We've since gone on to do dose finding studies in our sheep. And so we've had in groups of 8 sheep randomized to vehicle, 1 gram per kilo, 2 grams per kilo, and 3 grams per kilo. And really it seems like the minimum effective dose of sodium ascorbate for septic shock in sheep is 3 grams per kilo. Now, there are significant species differences between humans and sheep. Probably most important of which is that sheep can synthesize vitamin C, whereas it's an essential micronutrient for humans. We can't synthesize it, we need to eat it in our diet. But nevertheless, certainly in sheep, 3 grams per kilo seems to be the appropriate dose. And I've presented these data at some veterinary conferences and the crowd goes wild. They love it. Not that you're not going wild. Again, looking at the renal medullary oxygen tension, it appears that 3 grams per kilo is the right dose. And we've since gone on to do just like in the Bonanza study, so putting brain tissue oxygen monitoring in these septic sheep and able to show that with sepsis, you get a decrease in your brain tissue oxygen tension, but you can attenuate this with megadose sodium ascorbate at a dose of 3 grams per kilo. These are unpublished data. I can't see anyone with their phones out. Why would you? Oh, you're all on your phones. Don't screenshot. Okay, so if you're a sheep and you're in septic shock, our data would suggest that high dose sodium ascorbate may be beneficial. And this has been the impetus for the HIVIS trial, which is a phase 1 open label randomized control trial, which we are running through the Royal Adelaide Hospital, Royal Melbourne Hospital and Monash. We are aiming to recruit 30 patients with septic shock, not sepsis, but septic shock. And these patients will be randomized to receive usual care, 10 patients, an intermediate dose of sodium ascorbate, which is a 30-gram load, and then 30 grams twice daily for 2 days. So a total of 150 grams, which is about 2 grams per kilo, and about 10 times higher than has been given in previous trials. And then the final group are receiving megadose vitamin C. So they get a 30-gram load, then 60 grams twice a day for 48 hours. So a total of 270 grams. Or more than 3 grams per kilo. And yeah, that is 20 times higher than has been given in previous trials. So that is a trial that is underway in our unit. I'm only presenting this out of interest. This isn't science, but this is what happened. One patient so far has been randomized at the Royal Adelaide, and this is what happened. So this patient came in with a septic joint that had their hip washed out in theatre, and they were brought around to ICU on 25 mics a minute of noradrenaline and max dose vasopressin, so another potent vasoconstrictor at 2.4 units per hour. They were randomized into the megadose arm, and you can see they received the loading dose of 30 grams and the maintenance dose of 60 grams, by which point the vasopressin had been weaned off and the noradrenaline was down at single figures. During the break between the 60-gram loading dose, the noradrenaline crept back up to 10 mics a minute, and then during the second maintenance dose was weaned off. So that's been our experience with N=1. We have obviously 29 more patients to recruit into the trial. And so it really is watch this space, but it's an exciting area. It's controversial. It's certainly going to raise eyebrows, particularly given what's happened with the Lovett trial. And I'll be very excited to present these data maybe this time next year. So thank you very much for your attention. Thanks for following on your phone. And please contact me if you want to be involved in any research that we've got going.
Thank you so much for putting up with the terrible technical difficulties. I will not be able to undo that image of Nick Edwards. That's really disturbing. But I did like the Shaun the sheet, so, and the HIVIS sheet.
Yep.
You've put up some really great clinically relevant research to us today. And you've also alluded to the incredible culture within your unit that enables this kind of research. What is it about the ICU that enables this culture, this sort of sign up by multiple staff from multiple disciplines and professions, do you think?
I think it's led from the top, and it's a culture that has been fostered by Marianne and her culture of inclusivity. And we can see that with Leanne Chappell, who's a dietitian, having a senior role in the ICU unit, and also the research coordinators acting both within the unit and also on the floor. Within the ICU in general, it is there is a strong culture, I think, of understanding and appreciating research. So the journal club every week is well attended, and the ICU registrars and the consultant group have fairly robust debate on a weekly basis about trials. And there's this, and I think, an appreciation from the top down of what research is and And I think that then leads to increased capacity for our unit to conduct good research.
That sounds like it's really important and plays out very, very well. Do I have any questions from the audience? Excellent. If anyone online wants to ask a question, typing in the chat would be fantastic. You've alluded to the fact that some of those earlier vitamin C trials were not done with the higher pH, the sodium ascorbate, I think you said.
Yeah.
Do you think that pH, I mean, how does that pH work in ill patients? They're giving a lot of acid. Is that problematic?
So potentially, yes. It's a bit of a tricky question because when we give patients normal saline, the pH of normal saline is about 5.5 as well, and we tip that in by the litres.
Yes.
So I'm not convinced that it is a pH reason, but that is a significant difference between the two products. Yeah. What I didn't mention is at the moment we are randomising sheep to the ascorbic acid product or our sodium ascorbate.
Right.
And without giving too much away, it's fascinating. So there are big differences. It's going to be published hopefully in the next 3 or 4 months, but the ascorbic acid certainly in sheep looks to be harmful.
Okay. Interesting.
Why did you choose sheep?
Yeah, it's a good question. So sheep
can do anything to sheep?
Yeah,
apparently?
they're the right size. So mice, rabbits are too small in terms of blood sampling. So we need to sample the blood at regular intervals, and there's only so much blood in a mouse. Sheep are relatively easy to control, and their anatomy is roughly similar to human anatomy.
But they produce vitamin C.
Yeah, so a lot of animals produce vitamin C. Humans are kind of rare. So bats, capybaras, the guinea pigs, sheep, goats all produce vitamin C. Humans are a bit of the outlier.
Right, and now the battery's running low. Given the difficulties that we've had in your talk today, Mark, what I would like to do is invite people to enjoy the sandwiches outside rather than wait for the battery to completely conk out. Once again, can I thank you so much for doing without your presenter view and for presenting such an interesting range of research. It's fantastic.
Thanks, Jo.
Mark.
Thanks.